So I'm here today to discuss some recent work that we've had published as a team in Nature Medicine, and that's looking at actually the thromboembolic events and vascular dementia in patients with atrial fibrillation that are traditionally considered to be at low apparent stroke risk. As always, this is a collaboration. I was just lucky enough to lead this, but it's a team's work. So first of all, what we do. We'll get into actually, well, what is atrial fibrillation? So atrial fibrillation is the most common sustained cardiac arrhythmia affecting millions of people globally. It's expected to double in the next few decades thanks to an aging population and increasing comorbidities such as hypertension, obesity, diabetes, and stress that are associated with the development of atrial fibrillation. And also thanks to the increase in screening that we are now seeing thanks to the growth of smartwatches and other devices that can actually detect whether a patient has gone into atrial fibrillation. So atrial fibrillation is characterized by a rapid and irregular electrical signals in the atria, or otherwise known as the upper chambers of the heart. AF disrupts the heart's normal rhythm and impairs its ability to efficiently pump blood around the body. The frequency and duration of these episodes vary from infrequent short episodes turned paroxysmal AF to much more permanent maintenance of these fibrillations. This variation leads to a spectrum of symptoms that can range from none at all to severe and debilitating palpitations, fatigue, shortness of breath, and chest pain that really can affect a patient's quality of life. It's not just quality of life that is affected in atrial fibrillation, and they are also at risk of long-term health outcomes, with the rate of death, hospital admissions, regardless of any cause, actually doubled in AF, no matter of what the patient's age are. The risks come from, but are not limited to, the thromboembolic nature of atrial fibrillation. So that irregularity of those contractions in the atria actually cause turbulent flow and areas of blood stasis, which leads to the formation of blood clots that then have the potential to travel to other locations in the body, with AF patients at 3 to 5 times increased risk of thromboembolism, at sort of 4 times the risk of actually being admitted to hospital due to stroke, and those patients who do have a stroke due to AF actually having poorer outcomes than patients that have a stroke without AF. Now, quite rightly, treatment plans for AF focused on reducing the risk of thromboembolisms through the use of anticoagulation, which has continued to improve outcomes, and with more recent move from warfarin towards direct oral anticoagulants, we're actually seeing this continued improvement in outcomes, with actually a reduction in what would be deemed as a negative outcome, which would be major bleeding events. Now, quite rightly, and with all medications, we need to weigh up the benefits versus the risk. And this is no different with anticoagulation, as they do pose an increased risk of bleeding. So with this in mind, at the moment, anticoagulants are only targeted at those patients that are seen to be at high risk of stroke. And this risk of stroke is assessed through a clinical risk scoring system, which is termed the CHA2DS2-VASc risk score. Now, the CHA2DS2-VASc risk score gives patients with AF 1 or 2 points, dependent on what other vascular risk factors that they have, as these have been shown to increase the risk of stroke and include congestive heart failure, hypertension, diabetes, age, gender, and also prior stroke as well. The problem with CHA2DS2-VASc score is actually it's only limited in the ability to predict stroke risk. It's actually only just better than sort of flipping a coin. And what else? It actually doesn't consider other more long-term risks that are beginning to be more understood, particularly around the potential for AF patients to suffer from subclinical thromboembolisms that are asymptomatic and actually can lead to cognitive decline and vascular dementia. These white matter changes that you can see there on that MRI begin even at the age of 60, and then are potentially widespread well before anticoagulation would be considered in these AF patients. So it's clear to see that there's room for re-evaluating the way that we use anticoagulation in patients with AF. With that in mind, and with the aim to investigate if this risk of dementia is found in a more general population, we conducted a retrospective analysis of real-world data collected from primary care practices across England, with the aim to evaluate whether AF was associated with a broader range of thromboembolic outcomes, including vascular dementia and mortality, despite patients being at a low perceived risk of stroke. So the data that we chose to use for this was primary care data collected from the IQVIA Medical Research Database and collected between the 1st of January 2005 and the 31st of December 2020. IMRD contains pseudo-anonymized medical records collected from around 832 practices using the Vision clinical system, which is one of the 3 current providers for primary care electronic healthcare records. It contains information on patient demographics, diagnosis and symptoms coded using the RECODE classification system. And the IMRD database has been shown to be representative of the UK population, and past research has shown that primary and secondary care data has a high level of concordance. To extract the data, we use the data extraction for epidemiological research, the DEXA software that's been designed and built in the University of Birmingham, and provides the ability for healthcare data sets to be extracted, transformed and formatted with normalization and allowing easy analysis of that data. DEXA uses an interface designed to obtain data extracts specific for each research question and observational study. It allowed us the ability to input the requirements, the eligibility criteria for the study, define what we class as the exposed and unexposed groups, and also shows outcome measures and also baseline covariance that we would need to look at as a study. So with that in mind, and using DEXA software, we found over 16 million patients who have been registered for at least a year between our study period, of which 290,000 had AF and were between the age of 40 to 75, and 80,000 had no history of stroke or anticoagulation, and 36,000 had a CHA2DS2-VASc score of less than 2, and therefore were included in our study. These were matched with up to 4 patients without AF, and this matching was done on age, sex, and health authority region as well. So what did we find? So demographics were comparable between cohorts, with an average age and low level of vascular risk factors reflected in the mean CHA2DS2-VASc score of less than 1 in both groups, showing that we really had identified a low risk community here. We had a mean follow-up time of 4.4 years in AF patients and 5 years in the control patients, with a total of 831,000 person years of follow-ups for all outcomes. So what did the outcomes find? So what we found was the rates of stroke, ischemic heart disease, and arterial thromboembolisms were twice that seen in patients without AF. And although this was not unexpected, past studies have normally included older patients that actually have multiple comorbidities. And in fact, with annual event rates of 0.7% for stroke and thromboembolism and 1.6% for death, this study shows agreement with other studies that are using other retrospective data sets to assess perceived low-risk patients. One of the key outcomes that we feel is actually that increased risk of all-cause mortality, even after the adjustment for confounding factors such as age, sex, deprivation score, ethnicity, and hypertension and diabetes status. It was found that there was a 44% increase in mortality in patients with AF, despite, again, their low perceived risk. And this is something that rarely receives attention when looking at clinical outcomes. These results could indicate the need for earlier consideration of actually risk modification in these patients, and absolutely when we progress and look at the dementia outcomes, this is a potential. So AF patients were an increased risk of being diagnosed with dementia no matter the course. And this association seems to be driven by an increased risk of developing vascular dementia, as we saw no increase in the prevalence of Alzheimer's disease in this AF population. We feel that this ability to separate out the etiology of dementia is important, as it could possibly show a mechanistic link between AF and vascular dementia. Vascular dementia is a biological plausible endpoint for AF, with a potential multifaceted contribution from both clinical and silent embolic stroke, potential cerebral hypoperfusion due to the beat-to-beat variability in cardiac output found in atrial fibrillation, and also the shared risk factors found in both conditions. If you look at the risk factors, first of all, that lead to the development of AF, the risk factors that increase the risk of stroke and the risk factors that increase the risk of vascular dementia, you'll see that a lot of them overlap, including with hypertension, diabetes, age. Previous studies have shown this link between vascular dementia and AF. However, they tend to have included patients with an average CHA2DS2-VASc score of greater than 2. And therefore, we believe that this study actually extends this evidence into those lower risk communities. So just to summarise our results and just to sort of speak about some limitations to this. So in summary, patients with AF who are deemed to have a low chance of thromboembolism using conventional risk factors are still at a substantial increased risk of instant stroke, arterial thromboembolic event, vascular dementia, and death compared to matched controls. Obviously, there is always some limitations to studies. So first of all, we rely, using real-world primary care data means that we rely on the completeness of that primary healthcare records. Now, in the UK, we are particularly good at coding in our healthcare records, particularly primary care, thanks to the introduction of QoF early in the 2000s. But this absolutely, and the nature of AF and the fact that it can be asymptomatic does mean that actually we might be underestimating the effect of the sort of outcomes in this study. There was a limited ability to judge the dynamic risk as the CHA2DS2-VASc risk score changes dynamically. We weren't able to account for this in our analysis. And obviously, this is just an observational trial and therefore cannot show, can only show correlation and can't show causation. So, and I just wanted to sort of briefly touch on actually, well, what next? Where does this go? And we're lucky enough that we're already to that next stage. And as I said, observational nature of this study means that we can't show causation. But what we can do is actually lead this into a randomized clinical trial. And we are currently running this as a team. This is called the Dare to Think trial. And this is looking at preventing stroke, premature death, and cognitive decline in a broader community of patients with atrial fibrillation. And we're using healthcare data to make this a much more pragmatic research trial. If you really want to learn more about the Dare to Think trial and what we're trying to do and how we're using a pragmatic nature, I think the opening talk of these HDR grand rounds was actually me talking about how we're delivering the Dare to Think trial. But in a nutshell, we're looking to recruit over around 3,000 patients with a low risk of stroke, randomize those to receive anticoagulation, and then follow them up to see what their dementia outcomes are. Secondly, and I touched on this with actually the mechanistic aspect, So although this study shows that there's a potential thromboembolic effect, there was also potentially other reasons for this. And as a sub-study to the DARE-to-Think trial, we're running what's called the DARE-to-Think neurovascular study, and that's looking at the real mechanism behind the link between vascular dementia and AF, and actually how potentially oral anticoagulants might be able to affect that. So we've completed our baseline recruitment for that study. We've got over 168 patients recruited, and they have had brain MRI scans, in-depth cognitive function tests, and retinal vascular imaging to give a broad view of their vascular status. And we're looking at bringing patients in after 3 years for further follow-up. And then obviously linking in with the DARE-to-Think trial, we'll get their long-term primary care and secondary care records to answer our outcomes as well. So thank you very much. Thank you again for giving me the opportunity to speak, and I'm absolutely happy to take any questions as well.